And we're live in 5,
4,
3,
2,
1.
Well, good morning, everyone. My name is Clifford Pierre. I'm the neurosurgery fellow here at the Swedish Neuroscience Institute. I'd like to welcome you to the Cerebrovascular Question and Answer Symposium hosted by the Seattle Science Foundation. It is my distinct pleasure to introduce to you Dr. Colin Derdeyn, who's professor and chair of radiology and neurology at the University of Iowa Hospitals and Clinics. He directs the Iowa Institute of Biomedical Imaging. His practice primarily focuses on endovascular treatments of cerebrovascular disease, including ischemic stroke. He comes from an amazing pedigree of training, not only at WashU, but also did fellowships in neurointervention at University of Wisconsin-Madison under Dr. Charles Strother, and returned back to WashU to do cerebrovascular fellowship under Dr. William Powers. He has served in many leadership roles, including president of the Society of Neurointerventional Surgery, as well as chair of the Stroke Council of the American Heart Association and American Stroke Association. He's been actively involved in research and as well as advancing the field, having taken place and served in a position as executive investigator of several randomized controlled trials, including COST, SAMPRIS, MOST, and STEP. Also served on the data and safety monitoring boards for many of the present and former stroke trials as well. He's involved in research on novel stroke devices and maintains a robust clinical practice. We're excited today for his talk on the management of atherosclerotic disease. And we, again, can't wait to hear what he has in store for this symposium this morning. Dr. Colin Derdeyn, thank you so much for joining us.
Yeah, thank you, Cliff. And thank you, Corey and the Seattle Science Foundation. And thank you, Cameron, also. And I'm excited to be a part of this. And just before I launch into it, a couple just quick Seattle connections that I was talking about briefly before. You know, I spent a month out there in the late 80s as a medical student, fourth year, thinking about neurosurgery residency out there, and worked with Mark Mayberg at the VA, who incidentally, he was also the chair of the AHA Stroke Council, and I think first non-neurologist to be one, and I was the first interventional neuroradiologist to be the chair of that. And so he blazed a trail, and I think I came on board as one of the committee chairmen under him, and have enormous respect for Mark. And then I was out there with Dick Wynn and Matt Howard, who I'm currently my main partner in crime here at Iowa, was out there as a resident, and Dave Newell was the chief resident at the time. And anyway, some really neat memories of Seattle, and what an amazing medical community that is, and what a regional resource it is for such a multi-state area. So it's a great honor to be here and to speak. And I'll jump to my slides at this point. But I have a lot of nice, neat memories of my time there. This Cliff, am I okay now? Are you seeing my slides?
Yes, you're good to go.
Okay, so shifting to what the charge is here, what I was going to talk about is carotid atherosclerosis, carotid atherosclerotic stenosis, and this is a data-heavy talk. That's sort of my the lens through which I view the world, and having been involved in a lot of trials, and really being a big advocate for the value of randomized controlled trials and high level data in terms of guiding our decisions. And I think that's what this comes through. There's not going to be a lot of glitzy new devices or much in this. It's really where the data is and where we are now in terms of what what evidence we have for treatment. And it should be about 45 minutes or so, and plenty of time for questions at the end. I should also say, I don't think I'm wasting people's time on this, but this is my current role and position, but I'm here in Charlottesville today, going back to my roots where I started for College and Medical School, where I'm going to become chairman of radiology here January 1st. So transitioning further back east to my roots. Okay. In terms of roles that I play, I do have a notable conflict, which is that I chaired the DSMB for the Roadster trial, which was the pivotal trial that got FDA approval for the TCAR device, Silk Road. And I'm still involved in them with another DSMB of another clinical trial they're running. But beyond that, I don't have any other relevant conflicts. So some objectives, really, the primary one is recognizing the difference between symptomatic and asymptomatic carotid disease. The presence of ischemic symptoms has enormous impact on natural history risk and whether or not intervention is needed. And then there's also important impacts of gender, timing of intervention, and degree of stenosis that play a role in our decision-making about who should be treated and not. And then I'm going to talk a bit about the data for carotid stenting and TCAR relative to endarterectomy. Okay, so starting at first with stroke epidemiology. These data are old. They're probably still relevant. About 40%, I got to move my picture here. It's in the way of my words. It's too much. Okay, good. Up to 40% of patients that have an anterior circulation TIA or stroke have significant carotid disease. We see, I don't know how it plays out in Seattle and up in the Northwest, but in Iowa, this is where we see a lot of carotid atherosclerotic disease as in our stroke patients and our TIA patients. Carotid occlusion is also common in our population. And this comes from some pretty old data, but again, I think it's still relevant. And then this image, probably not for neurosurgeons is relevant, but for a lot of endovascular people who've never really seen the inside of a vessel, this is what we're talking about. And this is explant of a carotid endarterectomy specimen with an atheroma. It's beginning in the common, extending into the external and the internal, where we have this very ulcerated irregular plaque. And this is what we're dealing with when we cross this with a wire and a catheter and when we deploy a stent. And I think that comes into play later as we talk about microemboli and other kinds of things that distinguish endarterectomy from angioplasty and stenting. In terms of I can't see the title of my slide again. I need to move this. Oops. These are why does atherosclerotic disease cause stroke? There's embolic factors certainly are prime. You know, we know that retinal emboli, we see them in the retinal fields in patients with asymptomatic carotid disease. With transcranial Doppler, we see frequent microembolic signals coming from patients with asymptomatic plaque. And angiographically, we see distal emboli in many of these patients, and certainly we see it in our acute stroke patients. And this is another line that indicates that. However, hemodynamics, and I'm a hemodynamics guy, hemodynamic impairment, poor collateral flow, and the presence of distal autoregulation or increased oxygen extraction, it's a powerful and independent risk factor for future stroke in these patients. So the two are likely synergistic. And there's some good data that pre-existing hemodynamic impairment, an embolus in that setting is more likely to cause symptoms than in somebody with good collateral flow. And it doesn't really matter much for carotid revascularization, but it may come into play with carotid occlusion. It certainly didn't in cost, but there's some derivative studies that suggest that might identify a patient population that's going to benefit. And it may come into play with asymptomatic carotid stenosis, where treatment for all comers doesn't provide a benefit, but patients that have hemodynamic risk are going to benefit from that procedure. So it's important. It's an important thing to pay attention to. But clearly, embolic factors, plaque biology, intraplaque hemorrhage, lots of things, inflammation, but hemodynamics too. And this is my only slide on medical therapy. So it's good I'm talking to a surgical group. But there are important to note, there are no randomized trials for medical treatment for patients with carotid stenosis. And most of the secondary prevention trials excluded patients with symptomatic carotid occlusion or stenosis because of that risk factor. So, all of these angels on the head of a pin debates about how much aspirin and aspirin versus Plavix and hypertension and all those kinds of things, we really don't know specifically in this population, but in general, we extrapolate from the large trials to this patient population, and we come up with, antiplatelets, a statin, blood pressure control, glucose control. There is some interest. People have proposed repeating NASCET with an aggressive medical management arm, which was dual antiplatelets for 90 days, high dose statins, and blood pressure control. But I don't see this ever getting off the ground because that stroke risk is so high in patients with symptomatic carotid stenosis that I think very few people are going to feel comfortable randomizing to a medical arm. But there is some interesting questions there about what the impact of Sampras medical regimen would have in a symptomatic athero population. Okay, so I'm going to talk a lot about endarterectomy. I'm going to talk a lot about stenting. I'm going to talk a little bit about TCAR, and they really are very, very different approaches. TCAR and carotid stenting, not so much, but they're very different. And like we talked about with that specimen at the beginning, their risks and the risks of those procedures are very different because they're so fundamentally different in how they tackle this plaque. Just a quick image again. This for surgeons probably not that important, but how we approach the carotid artery. For stenting, this is a balloon-guided procedure here where we've got a balloon in the common. We have a balloon protecting the external, and then we're performing an angioplasty of this tight lesion and then placement of a stent afterwards. And then TCAR is a little bit of a hybrid where there's a surgical cut down in the neck, similar to what would be done for an endarterectomy. There's proximal control gained in the carotid and placement of this a balloon guide where the balloon is inflated, so you're performing this procedure under flow arrest, and it's more than flow arrest because you hook this up through a circuit to return blood into the femoral artery, and so ideally, theoretically, it's under flow reversal so that any emboli that are generated crossing this, doing angioplasty and deploying the stent are filtered and then go back into the venous circulation. There are issues with this, and that if you don't isolate the external in a fair number of patients, you may be getting retrograde flow down the external, but it's still going to be going antegrade up the carotid despite having a balloon here. But that's just a minor technical aspect of TCAR. In terms of technology, there is some emerging. This is my only sort of emerging technology slide before I beat you all to death with trial data. But covered stents have some potential for reducing microemboli or macroemboli during the carotid stent or the TCAR procedure, both during the procedure and in the hours and days afterwards. There are certainly ways of doing better distal or proximal protection with balloons or with distal filters, and then neck access, which is really just the TCAR device. All right, now into the data beating. So we're going to talk about symptomatic first and then asymptomatic. And I meant to take this out. I'm not going to talk about carotid occlusion. I don't think we'll have time for that today. I see a chat here. Oh, okay, posting questions, great. Cliff, are you going to manage the chat for me, or can you?
Yes, yeah, I'll be
Okay.
managing the chat. We'll save time after your talk to address those questions. Thank you.
Okay, thank you. All right, so the big trial to start out with, and for the senior folks on this call, I think this is nothing new, but for the trainees, this is a big deal. So the North American Symptomatic Carotid Endarterectomy trial was the first major positive trial in our space. It was done by the neurovascular people from London, Ontario, Western Ontario, which included Charlie Drake. And it came on the heels of the ECIC bypass trial. It was the same group where they failed to show a benefit for bypass, but they took their study infrastructure and they did NASCET. And it was the first major positive trial in the cerebrovascular world, and it really defined medical management or treatment of carotid disease, and it still does in many ways. And so randomized trial of surgery versus best medical therapy, which was high dose aspirin, about 325 milligram doses. Patients had to have recent symptoms within 90 days of a TIA, amaurosis, or ipsilateral stroke. The primary study, or at least the initial study, focused on patients with high-grade stenosis. Endpoint was any stroke or death, and they found a dramatic risk reduction with surgery. And just as a digression, just to talk a bit on the NASCET method, which we still use, it's taking the narrowest diameter of the internal carotid and expressing that as a fraction of the normal distal ICA. So it's really A over B, and this is going to be a high-grade stenosis. This is an example of somebody with a big plaque, but no measurable stenosis. And so for NASCET, that's really going to be no stenosis. The European carotid stenosis trial used a different way, and this would have been stenotic, but we don't use that method anymore. But this measurement of stenosis is the coin of the realm. It's really how we calibrate ultrasound results. It's how we express CTA and other results. There are certainly, it's an interesting thing to talk about and think about, because degree of stenosis is certainly a factor for stroke risk and embologenicity and hemodynamic risk, but it's not the only one. It doesn't take into account the length of stenosis. It doesn't take into account cross-sectional area. It doesn't take into account intraplaque hemorrhage or ulceration or all of these other factors, which certainly reflect embolic or hemodynamic risk. But because NASCET proved benefit, it's what we're sort of forced to use as being the ground truth for how we make decisions. And we throw those other things in the bucket when we make decisions, but still the only validated, proven predictor of stroke risk and benefit is the NASCET criteria. This is pooled data from NASCET and the ECST, where Peter Rothwell is a stroke neurologist from England, went back and remeasured all the ECST, the European carotid stenosis trial, in the NASCET so that the data were consistent. And these were the final results. So this is the medical treatment group in the light, or the black line here. The heavy black line is surgical. These are the number of patients available for follow-up at each year, going out to 10 years. And then this is the cumulative hazard curve. These are each is a 10% risk of ipsilateral stroke or 30-day perioperative stroke risk. And you can see the surgical group takes a hit here in the 70 to 99%, but rapidly those lines cross, and there's a durable benefit for endarterectomy way out to 10 years, although the number of patients that are followed that far are pretty limited. But this is a massive positive benefit with a really, really high number needed to treat, and something that's just extremely compelling is for treatment benefit. 50 to 69% symptomatic. The lines do cross. There is a durable benefit, but that benefit's a lot more marginal, and it's not as profound a benefit, but there is a benefit. And then below 50%, really no benefit, and maybe even harm for the less than 30% stenosis. Near occlusion, I'm going to talk about in a minute, but relatively limited numbers. It's not a primary endpoint of the trial. Many patients with near occlusion that were symptomatic may not have been included or randomized, but it is a pretty high number of patients, and so it's an interesting thing to talk about. And my next slide goes into that. And near occlusion by NASCET, because the entry criteria was 70% stenosis, in near occlusion, you have a high-grade stenosis and then collapse of the distal ICA because of low flow. And if that distal ICA, because that numerator has the denominator is falsely low. So the criteria for calling something a near occlusion was ICA smaller than ECA, and on the ICA flow being slower than external carotid flow. So here we have the internal carotid artery coming up to the level of the supraclinoid, but it got there slowly, and we see superficial temporal and occipital filling ahead of it, which ordinarily in a low resistance circuit in the brain ought to be filling well ahead of these extracranial branches. So this is how they define near occlusion in NASCET. People also call this a string sign, where the distal ICA is collapsed. It's a normal vessel. It's just collapsed from low flow. And if it's revascularized, it will plump up rapidly to being normal. But this is where, if this is another graphic of that same data, this is the natural history of these patients with 30% all the way up to 70, 99. And the natural history of these near occlusion patients, it's much lower than patients with high-grade stenosis. And this has been recognized for a while, and people think that either it's because there's less flow, so there's less embolic debris that floats up into the head, or the other idea is that, which is, again, this is all speculation, that the only way the ICA collapses to such a low flow state is if you have good collateral flow. And I don't know if that's totally true, but both of those things may be factors that make these not as much of an emergency or an urgency as a symptomatic high-grade stenosis, and also something where the benefit may not exist for revascularization, and it's something where you need to put a little bit more careful thought on whether or not that needs to be treated. Okay, I'm going to pivot now, and I'm going to talk a little bit about gender. And this is relevant to endarterectomy here primarily. We don't have this so much for stenting, but perioperative risk for the 30-day perioperative stroke and death rate plus subsequent ipsilateral stroke. This is an absolute benefit, and then this is above 0 for men, but it's below 0 for women. It suggests that women, actually, I think I'm missing I'm going to skip this slide. This one gets at basically what this is telling us is that women have higher perioperative stroke risk and lower risk of stroke with medical therapy, and that this is where this comes in. So here's a little bit higher risk of perioperative stroke for women and a little bit lower risk of stroke on medical therapy. The benefit of endarterectomy and revascularization in general is less in women than men. And then this is a slide that ties this all together for degrees of stenosis, timing, and gender. So these are absolute risk reductions, taking the stroke risk, at 2 years from the surgical group compared to the medical group, including perioperative risk. And for male patients with gray is 70 to 99% stenosis, white is 50 to 69. For male patients with high-grade stenosis, even out to 12 weeks after the index event that led them to be randomized in the trial, there's a benefit of endarterectomy. For women, that benefit diminishes with time. So if your stroke that got you into NASCET was 2 weeks ago, definite a benefit. With with, I'm sorry, I'm confusing these slides. Women are below. This is 50 to 70% stenosis for men. So for men with less degrees of stenosis, there's more of a time-related diminishment of benefit. So most of the benefit is up front, especially for the lower grades of stenosis. For women, within the first 2 weeks, huge benefit of early intervention. But as you go longer, there's less benefit. And in fact, maybe even benefit lost, particularly as you get into lower degrees of stenosis. So this just demonstrating that time, degree of stenosis, and gender all play a role in how much benefit we see from revascularization. And then the last one is age. And we'll talk about age more because there's some really relevant issues related to angioplasty and stenting with age. So this is all patients. This is the 50 to 69% patients, and these are the greater than 70. And these are broken down by less than 65 years of age, 65 to 74, greater than 74. And what you see is that this is 30-day perioperative stroke and death plus ipsilateral stroke, and these are absolute risk reductions. And so what you see is that really the older you are, the more benefit there is. And particularly as you get even older here, even though there's higher perioperative risk in patients with that are older, the risk on medical therapy is even higher. So the benefit of endarterectomy in a patient over the age of 75 is higher than the benefit of younger patients. So to sum up the endarterectomy data, given a perioperative stroke and death rate of 7%, which is what NASCET and ECST had, shows a powerful benefit for men, more than 50%. For women, more than 70%. Should not delay. Early endarterectomy is better. And I'm not going into that data. There's no randomized data on timing, but there's a lot of case series data on timing, and more of it indicating that the earlier intervention has real advantages. Older age, definitely not a contraindication to endarterectomy. And if anything, probably a reason to lean towards it rather than stenting. Level 1 evidence for CEA for symptomatic stenosis, and all of these other things I'm talking about are post-hoc. Okay, so now let's talk about carotid angioplasty and stenting. The existing trial data here is a little bit confusing and hard to navigate because most of the trials included both symptomatic and asymptomatic patients for pragmatic reasons that I'm not going to really go into. But the problem with it is that these patients, symptomatic and asymptomatic patients, are going to have much higher or much different procedural complication risks and outcomes, probably because of the underlying disease. And the other confound is that these trials also included MI as a primary endpoint, and NASCET and ECST did not include an MI as an endpoint. And that adds to some controversy about angioplasty versus endarterectomy. And this is just the CREST trial data. This is Tom Brat and his group, and this was the pivotal trial demonstrating substantial equivalence of carotid angioplasty and stenting to endarterectomy. But that I'll show you as you dig into it a little deeper, they're really not that equivalent. I mean, we're talking small percentage numbers, but they're not that equivalent. So these are the 4 trials that have been randomized between stenting and endarterectomy. And what I'm showing you here is the patients in them separated out, the patients with I lost my arrow there. That separated out between symptomatic and asymptomatic. So these are the symptomatic patients in these 4 trials, because there were asymptomatic patients included that I've removed. And what you see is the numbers are large. And I've got CAS and CEA. MI not reported in EVA 3S space, but it was used in CREST and here. And so what you can see is that for EVA 3S, angioplasty and stenting versus endarterectomy for stroke and death, space, CREST, ISIS, all of these show higher rates of stroke and death in angioplasty and stenting. If you add in MI, they get a little bit narrower, but they're still not equivalent. Now, CREST showed substantial equivalence, but it's because of their primary endpoint included angioplasty and included asymptomatic patients. And so this really wasn't the primary hypothesis being tested, was whether or not it had provided a benefit in symptomatic patients. But this is really where the controversy comes from, is that whether or not including MI is really relevant or appropriate, and also the fact that symptomatic and asymptomatic were not split out in those trials. Coming back to age, I just want to talk a little bit about that. One thing that comes out pretty consistently with angioplasty and stenting is that as you get older, stroke risks with that procedure get higher. And so this is hazard ratios here on the y-axis, and on the x we have age greater than 60, less than 60, and then by 5-year epochs to greater than 80. And so these are pooled data, those 4 trials I just showed you. For endarterectomy, there does not appear to be any real increased risk of stroke with age, increasing age. However, with angioplasty and stenting, it does appear that there is a real increase of risk with increased age. This is the peri-procedural on the top, and this is post-procedural on the bottom. And I think the next slide talks a little bit for why this might be. And it may be small vessel disease and the ability to clear emboli. And so it may be a signal of microembolic debris from the procedure and the consequences of microembolic debris in the aging brain. So the blue here is carotid stenting, the red is endarterectomy. These are different scores for white matter disease. I can't remember what this is from, but from a white matter disease score. A is any stroke, B is non-disabling stroke, and C is fatal or disabling stroke. The more white matter disease burden you have, the higher risk of stroke, any stroke, non-disabling stroke, or fatal disabling stroke, not quite so different, but you can see the impact of that. So to sum up the symptomatic carotid stenosis here, with what we're talking about, endarterectomy and CAS, and I'll come to TCAR at the end. Good surgical candidates, we have level 1 evidence for carotid endarterectomy from NASCET and ECST. CAS is reasonable for patients that have high operative risk in terms of access, anatomy, MI risk, certainly not age. And microemboli may be the biggest challenge we have, and that's why I think we're covered stents and better protective devices come in. Now I'm going to talk about asymptomatic patients for a bit before looping in TCAR. So here we have 2 trials that showed a benefit for endarterectomy in asymptomatic patients. ACAS, American Asymptomatic Carotid Atherosclerotic Study, and then ACST, which was the European ACAS. However, in both of those studies, these studies were done in the 90s, the annual risk of ipsilateral stroke was 2% or less. And there's a lot of reasons to think that natural history is much better. And that's why CREST-2 is underway. There's also the ECST2 trial, which is the European CREST-2. And those will both inform what the benefit is for asymptomatic patients. Because again, there's a lot of controversy here about whether or not there's a benefit of endarterectomy or CAS in asymptomatic patients because of this lower natural history risk. There are some non-inferiority studies for CAS versus endarterectomy. So there's no proof of CAS proving benefit for asymptomatic patients, but there are studies that show that angioplasty and stenting is equivalent, or at least non-inferior to CEA, and that's CREST and ACST. And again, that's because of the MI inclusion, but which you can debate. So ACAS I'll talk about because that's really the predicate study for benefit in this population that everything else hinges on. It took asymptomatic patients, better than 60% stenosis, mostly selected with ultrasound, although angiography was used for calibration. Endpoint was any stroke or death. And here there was a small risk reduction with surgery. And I say for men, the study took men and women. The primary endpoint was for men and women. It's a subgroup post hoc analysis that women don't benefit as much, but it's pretty compelling, and I'll show it to you. They have a 1% annual absolute risk reduction. NASCET was about an 18% 2-year risk reduction. So a dramatic difference in benefit and stroke risk reduction between these two different populations. These are subgroup analyses from ACST. So the weird thing about ACST from a clinical trialist point of view is that they published the results without publishing the perioperative complication rates. And they basically said, okay, you need to plug in your own perioperative complications and decide whether or not you're providing a benefit for asymptomatic patients. So what you're seeing here is 5-year risks of stroke after surgery, assuming you didn't have stroke from surgery. So it's sort of like if you had the perfect procedure, what could you hope to see? And you can see that there's a definite, anything that crosses 1 is not a benefit, it's equivalent. So benefit for men, benefit for women, although it's trending to be neutral. And again, that doesn't take into account perioperative complication rates. Age starts to get worse in the higher age groups. Interestingly, and I'd like to call attention to it, in ACST, they did not see any increase in stroke risk with higher degrees of stenosis. These are the medical groups here, and the stroke risk, 9, 5, 11, 8%. So 5-year risks of stroke here that were all the same, regardless of the degree of stenosis. So degree of stenosis for an asymptomatic patient may not be an indicator of a higher stroke risk like it is for symptomatic carotid disease. And then this is the big one here for gender. These are the risks of the benefit of endarterectomy for men and women from pooled data from ACST and ACAS, including the perioperative events. And so here you see for men, definitely a benefit. Here's from ACST and ACAS. For women, including the perioperative events, we really see no benefit for endarterectomy in an asymptomatic woman. Now, I'm shifting gears here now to carotid stenosis. And these, again, are non-inferiority studies against endarterectomy. And our predicate for benefit is ACAS and ACST. So CREST here, you can see for any stroke or death, we trend for higher risks in the angioplasty and stent arm, same for ACT in this case. When we add in MI, we start to see much more of the same. And here's the plus the greater than 30-day ipsilateral stroke risks. And this is really what drove the non-inferiority result of CREST, was the inclusion of asymptomatic patients. And again, for symptomatic patients, I think it's a little bit of a different story. Now, these are the medical arms or natural history study of patients with asymptomatic carotid disease plotted by year of publication. And a couple little ones that this paper came from not Rich Nail, I can't remember his first name, but he's a British vascular surgeon. And then these are labeling a couple of these recent studies. which actually aren't that recent anymore. But what it shows is the risk of any stroke or ipsilateral stroke over time of publication, suggesting that modern medical management is having an impact on stroke risk for asymptomatic carotid disease. And this is what drove CREST-2 and ECST2 to revisit whether or not endarterectomy has any benefit in asymptomatic patients. There was a recent publication of ECST data, presentation at the European Stroke Conference in Munich. This trial is a randomized trial of surgery, which is mostly endarterectomy, but some CAS versus medical therapy. They're taking asymptomatic patients with greater than 50% stenosis, but they're at relatively higher risk for stroke than, and I can't remember what the epidemiological factors are that put them at a slightly higher risk. Their endpoint is any stroke or death or perioperative MI. Their 2-year risks of stroke were the same between medical and intervention, but it's a very high risk because, in ACAS, it's about a 2% annual risk of stroke on medical therapy. And here they have a 10% 2-year risk. So I don't really know who their patient population is, but the outcome seems similar at 2 years. And if the curves don't cross at 2 years, they're probably not going to cross. So that's going to be something to keep an eye on. Okay, my last few slides about TCAR. TCAR doesn't have any good level 1 evidence. It's got a lot of case series, it's got a big registry, and it's got a huge PR campaign going on driven by vascular surgery, and that's probably a little unfair, but it is, there are advantages to this procedure, but there's not great science behind it yet. There's a special edition of the Journal of Vascular Surgery, which had multiple papers that were all drawn from the Society for Vascular Surgery quality registry. And this is one of the bigger ones where they had 3,000 TCAR patients, 10,000 angioplasty and stent patients, and 61,000 endarterectomy patients from a 5-year period that they compared outcomes to. And these were all in-house outcomes, and this is a registry. So there are all kinds of different reasons why, and demographic and epidemiologic reasons, differences between these patients in terms of comorbidities and anatomy and so on. So it's really apples to oranges to pears, but it's controlled as well as it can be. And this was mostly focused on age. These are odds ratios, so 1 means equivalent. The dotted lines are 95% confidence limits. And what they show is really, in this controlling to the extent that you can, these differences in comorbidities and so on statistically, they showed that TCAR was really very much equivalent to endarterectomy and across all ages. But with carotid stenting, they showed, here we have carotid stent being superior below the line and TCAR above. They showed as age goes up, TCAR is superior to carotid angioplasty and stenting. And that was not borne out in some meta analyses. I'll show that in the next slide. But it may be true of the patients that are in this registry. And there likely is, and as we talked about before, there likely is an age-related increase in risk with carotid angioplasty and stenting, which may be related to microemboli. And TCAR's ability to reverse flow, which is also something that can be done with transfemoral angioplasty and stenting. That may be a very effective way. I think covered stents and flow reversal may come in as being a very effective strategy for reducing microembolic events. But that's what I think a lot of this difference for stroke and death is driven by. So this was a meta-analysis that I was a part of, that one of our stroke fellows did, that's been recently accepted for publication. But looking at all the published patients for TCAR versus CAS or for endarterectomy, we don't see a difference in outcomes between TCAR and angioplasty and stenting. So To what extent this is really a major factor, I don't know. I believe it probably is. One last thing I wanted to say before I stopped, it's this concept of the high-risk asymptomatic patients. And for a while there, and this potential conflation of what high risk means. And what we really want to find is the patient with an asymptomatic carotid stenosis that's at high risk for stroke. And when angioplasty and stenting first came out for carotid disease, or at least in the first few years, people really were looking at it as being an alternative for endarterectomy for patients that were at high risk for endarterectomy. And Sapphire was one of the trials that was done for approval of the J&J device, and they targeted patients at high risk for endarterectomy. So these were their inclusion criteria, which included bad heart disease, bad pulmonary disease, prior surgery, and old age. And these were their inclusion criteria. They did have, it was a randomized trial between endarterectomy and stenting. So this is asymptomatic ACST perioperative complication rates, which is all comers asymptomatic patients. This is Sapphire high risk, and yes, those patients were at high risk for endarterectomy, 10% perioperative complication rates in an asymptomatic patient. And Sapphire was able to lower that complication rate significantly. And then this is when you combine the outcomes with the post-operative, the greater than 30-day ipsilateral stroke risk. So here you see Sapphire endarterectomy, where you had high complication rates and pretty high post-op stroke rates. Sapphire perioperative complication rates with pretty high subsequent stroke rates compared to ACST surgical and ACST medical at 1 year. So my point of this one is basically, yes, angioplasty and stenting provides a better outcome than endarterectomy in patients that are at high risk for endarterectomy, but we shouldn't be treating those patients. That's pretty much my point, that if you're at high risk for endarterectomy and you're asymptomatic, you probably should just not be treated. And this is the best data we have for that. So to summarize the asymptomatic data here, CREST-2, ECST2, they're going to help us revisit this question of revascularization, CAS, CEA, or TCAR for all-comer asymptomatic patients. High surgical risk patients, like in Sapphire, are unlikely to benefit. And focusing on identifying high-risk subgroups, either embolic or hemodynamic, are going to be very important for future studies for patients that may benefit from revascularization. So thank you very much.
Again, Dr. Derdeyn, thank you for that excellent, review for atherosclerotic carotid disease. And I see Dr. Monteith has joined us, and some of my other co-fellows, and Dr. Lowe is on. I'm going to open up the floor to questions at this time, and I'll field questions from the chat. Dr. Monteith, your hand is raised.
Thanks, Colin. That was great. Thanks, Cliff. I had a couple of questions. So first of all, great talk. Thanks for coming. It's a really great summary for all our fellows and residents, as well as some of us older folk who may have forgotten how everything kind of fits in terms of the trial data. Two questions. One is with regards to the registries you mentioned for TCAR. How do you see trial outcomes or data being different with the kind of rigorous randomized trial data versus a registry, and how do we kind of navigate that in terms of the inference of outcomes? And then the second question is, do you see any changes in practice given the new CMS guidelines for carotid stenting? I'd be curious to see how you think that may impact people's practice. Thanks.
Yeah, thank you, Steve. And thanks for attending, and I appreciate it. And it's a data heavy talk, but it's good. I think for trainees, you got to know the background of what's going on. And your two questions are great. It's so hard to do randomized trials. It's so expensive. They often are not that translatable. They don't reflect real world practice. And there's a huge value in well organized, well executed registries. But there are going to be limits to what you can understand. I think relative benefits of things, I think there's a lot to be gained. It's really when you get to comparisons against natural history that the real challenges happen. I think that's where the randomized data comes in. I think for the SVS registry, I don't want to say things that are way too, that aren't fair or are potentially insulting, but that data is largely vascular surgeon driven data who are excellent at endarterectomy, who are really good at TCAR. And I'm sure that many of them are really, really good at carotid stenting, but a lot of them, that's the only time they're in that carotid artery. And I think embolic risk and selection off the arch and there are some data that were pretty early on from CREST lead-in that there were differences between specialties in complication rates. So you have to take that into account too. And I think that may be a little bit of the factor that the meta-analysis doesn't show the same thing that SVS registry does. But there's great value to registries, but there are limits to what you can do, and there's limits to what you can control statistically. But in this data-driven, the electronic data we have available, I think more and more of it. We'll see more of it, and we'll get better at using it. The second question about the payment, the fact that you can, what Steve was referencing there was that CMS announced just a couple of weeks ago that they will reimburse now for asymptomatic carotid stenosis, angioplasty, and stenting, which prior to that you had to be in a clinical trial to do. And those clinical trials could be registries or industry-sponsored trials or any number of different things, and which in sometimes was a workaround that allowed people to treat, but which is kind of a cynical view of it. But I do think it's going to, personally, I think it's a bad thing. I mean, I think of all the unconscious biases that get dumped in the bucket when we look at patients, and knowing that we're going to be paid for it is something. And I think there will be increased utilization of stenting in asymptomatic patients, and I think it's unlikely that we're really providing benefit for a lot of them. And so, but I'm optimistic that CREST-2 and ECST2, CREST-2 closed. So CREST-2 results, there's a long follow-up, but CREST-2 data will be out, and that will help us. So I'm optimistic that will give us some clarity about whether or not this is a good thing or not. But my fear is it's not a good thing. This is a data point I don't have recent data, but it was 10 or 15 years ago. Asymptomatic carotids are not treated in other countries. We're unique on the planet in the volume that we perform here. So.
Yeah, I think, thanks, Colin. Great comments. I'd also add, if you look at the Roadster and these other registries, the number of asymptomatic carotids was dramatically higher than certainly what we see in our practice. We seem to get all the hot carotids, but that group of surgeons seem to get a lot of asymptomatic. So good points.
One of our fellows, Dr. Capek.
Oh, yeah. Thank you, Dr. Derdeyn. There was an excellent talk. I think my question was mostly answered already. I was going to ask about the SVS registry, since I have to say I'm really looking forward to reading the meta-analysis, because I think the registry, it's massive, but it's self-reported, and there are some red flags, like I think the comorbidities in TCAR group are significantly higher than in a carotid stenting group, which is very counterintuitive.
Mm-hmm. Yeah, and that's a good point, Stefan. I think the self-reporting is a big problem with the registries, right? You're right, and I think the that's one of the other major values of a randomized trial, is that the outcome assessment and the reporting is so carefully monitored and often independently done. And it's really amazing how the results of randomized trials come up with outcomes that are so different from what we've seen in prior case series and registries. The complication rates are often so much higher than you think.
Yeah, no, thank you very much. It was a great talk, and congratulations on your next endeavor. There are a few UVA people here.
Yes. Oh yeah. Oh, yeah, I'm excited about it. It's a neat chance to go back to my alma mater, and also my dad was on the staff here in the medical school in psychiatry, and a lot of deep connections to this town. So it's kind of a neat place for my last chapter. Kind of like Cameron coming back to the Pacific Northwest.
That's right. Yeah.
Definitely. I had one question. I guess in your experience, you mentioned again hemodynamics as well as microemboli. Are there, in your algorithm, especially as you transition back to Charlottesville, is there any image modalities that you're doing part of your workup when you're trying to qualify a particular patient to a particular treatment, CAS, TCAR versus CEA, in terms of, as you mentioned, plaque hemorrhage, plaque rupture, of that nature? What's part of your workflow and workup?
Yeah, I'll have to see what they're using at Virginia. I don't know yet, but I'll take what would be the ideal workup. I think for symptomatic patients, it's pretty straightforward. I think if you're symptomatic and you've got a high-grade stenosis, you've got to go. And there's not a lot of nuance, I think, in that population. The near occlusions have nuance because I think there's probably not the same hot risk there is. And that one, I might do something to look at hemodynamics, and also think a lot about age and procedural complication risk, and there's some that I might pass on based on some of that. For asymptomatic patients, I hew pretty close to this. I mean, I really don't offer it, right? Discourage women in my practice from having intervention. For men, I really steer them to CREST and to trials. I was with CREST closed now, and we were a site for CREST too. For CREST, that one, and the other CREST thing that's coming out is CREST H, that's looking at hemodynamics and cognitive outcomes too. And there's a story there as well that's kind of interesting. But to come back to the question about selection, I think for asymptomatics, for asymptomatic men, first thinking of trials, and then with CREST gone, I probably would just do it straight up stenosis. But I think looking at plaque, you can make a very good argument for trying to, and I know that Giuseppe in other Virginia, Lanzino at Mayo, I think part of his algorithm is getting a high-res MR of the neck and looking at plaque features.
Yeah, I saw that. Excellent. If there are no other questions from our other panelists or attendees, again, we thank you for your time, and again, congratulations on the new role that you're going to start in January in Charlottesville at UVA. So, Dr. Monteith, do you want to say anything?
Yeah, best of luck in Charlottesville. UVA is a great place. It's a great school, and I'm sure the neurosurgery and neurorad residents will enjoy having your expertise, and we look forward to seeing your output from UVA. Best of luck, and thanks again so much for joining us here today.
Oh, it's a great honor and pleasure. So this was a lot of fun, and thanks for reaching out. Greatly appreciate it, and great to see all y'all.
Colin, take care.
Yeah.